The following podcast is part of a certified educational activity titled New Advances and Opportunities for Improvement in Hormone Receptor Positive, HER2 Negative Early Breast Cancer. Practical Strategies for Optimal Clinical Integration of Adjuvant CDK4 and 6 Inhibitor Therapy. Access the entire activity and complete the post-test at peerview.com/AGM860. Downloadable slides and practice aids are also available.
My name is Sarah Tellini. I'm a breast medical oncologist at Dana-Farber Cancer Institute. Today we're going to be talking about advances and opportunities for improving outcomes in our patients with early stage hormone receptor positive, HER2 negative breast cancer, really with a focus on practical strategies for integration of CDK4/6 inhibition in the adjuvant setting. As we know, about 30% of patients who are diagnosed with hormone receptor positive, HER2 negative early stage breast cancer are at risk for recurrence. And this risk increases as clinical pathologic features increase in risk. And so because of this, we know that new treatment options are needed to help us prevent recurrence in these higher risk hormone receptor positive breast cancer patients. And in fact, we have made progress in this area with results that have recently come out from Monarch E, leading to FDA approval of abemaciclib in patients with early stage hormone receptor positive breast cancer. With this now approval, it really leads to the importance of having further discussions about the clinical implications of use of abemaciclib in this setting, and really thinking about optimal ways to integrate CDK4/6 inhibition in our early stage patients. So when we think about treatment for early stage hormone receptor positive breast cancer, for the last several years, we've really only relied on the use of endocrine therapy alone in this population. We've been fortunate to have agents like tamoxifen and aromatase inhibitors, and even availability of ovarian suppression, particularly for our premenopausal patients. However, even with the integration of these robust endocrine agents, there still are patients with high-risk hormone receptor positive breast cancer who unfortunately recur despite this therapy. So I think this case sort of puts into perspective the unmet need that we have now in our patients with hormone receptor positive disease. So this is a 54-year-old postmenopausal woman who had undergone a mastectomy and axillary dissection for a early stage breast cancer, but at the time of surgery was in fact found to have 6 centimeters of intermediate grade invasive lobular cancer within her breast, and upon axillary dissection actually had 3 involved lymph nodes. Given data that's come out from our exponder, this patient did have a genomic assay performed off the breast tumor, which came back with an Oncotype DX score of 8. This tumor was very strongly ER and PR positive and HER2 negative. And so we'll circle back to this case later on in our discussion, but I think it frames nicely a case for where we're looking for additional therapy to help prevent risk of recurrence. So data for use of CDK4/6 inhibition in the early stage setting really comes from the Monarch E study. This was a pivotal registrational trial that took patients who had high-risk hormone receptor positive HER2 negative disease and randomized them to receive 2 years of abemaciclib in combination with their endocrine therapy or to receive their endocrine therapy alone. The patient population in this study again was high risk, and this was defined as having 4 or more positive lymph nodes or being node positive with 1 to 3 positive nodes and having a tumor that was over 5 centimeters or was high grade. This was the definition for high-risk patients in cohort 1 of this trial. There was also a cohort 2 in the study that was specifically for patients who had high Ki-67 but did not meet the other criteria for eligibility, meaning they didn't have a tumor over 5 centimeters and were not high grade when they had 1 to 3 lymph nodes involved. This cohort was smaller relative to the overall population of the study and was only about 500 patients. But the primary endpoint of the study was to look at invasive disease-free survival. And as was noted, this trial did enroll high-risk patients. You can see here that when looking at number of patients who had large tumors over 5 centimeters. That was around 20% of the population. When you look at those patients who had 4 or more positive nodes, in fact, that's about 60% of patients in this trial. Most patients had grade 2 or 3 disease. And then this will be important as we circle back to the FDA approval, but when you look at the percentage of patients who had high Ki-67, it was about 45% of patients in the study. So we've now seen data for the primary endpoint of this trial, which is invasive disease-free survival. The study demonstrated that giving 2 years of adjuvant abemaciclib in combination with endocrine therapy did reduce risk of invasive disease-free survival events by about 30%. And the absolute difference between the two arms was 5.4%. And this was seen with about 27 months of follow-up in the intent to treat population. When you look at outcomes across all subgroups, you can really see that there is not a subgroup that is not deriving benefit from abemaciclib. So really, whether you had 1 to 3 positive nodes or 4 positive nodes or were premenopausal or postmenopausal, all these different subgroups of patients are deriving benefit from therapy. Importantly, when you look at distant relapse-free survival, you also see a very significant reduction in events. So there was a 31% reduction in distant relapse-free survival events, with an absolute difference of about 4% between the two arms. When you actually look at where these distant events were, they were predominantly bone and liver metastases, which I think is important to realize because this is really preventing true metastatic events that can eventually have implications on survival for our patients. We have now seen several analyses from Monarch E. The first analysis that we had seen had come from the second interim analysis at the time point where we had actually gotten positive data back. There was then data from the primary outcome of the trial, and then subsequently data from an additional analysis that actually had been requested by the FDA that had 27 months of follow-up. And so when we look now over time in a piecewise way, looking at benefits that were achieved with between years 0 to 1 and then subsequently 1 to 2 and then 2+, you can see that the piecewise hazard ratio actually improves with time. So originally, if you look between years 0 to 1, the hazard ratio is about 0.79. However, when you get to year 2 and beyond, the hazard ratio is about 0.6. And so again, I think this is important because there has been some concern about whether or not the benefit of adjuvant CDK4/6 inhibition could go away, particularly at that 2-year and beyond time point, at which point patients have discontinued their adjuvant abemaciclib. And so here you're seeing, in fact, continued improvement, which I think, again, is really reassuring given initial concerns that maybe the curves would come back together with further time. But given these very robust data from the trial, we did see FDA approval for this abemaciclib regimen. So the approval came for patients who met the high-risk criteria in Monarch E, but interestingly was also for patients who had a Ki-67 that was greater than or equal to 20%. And so many of us wondered why it was that the FDA had chosen not to just grant approval to the intent to treat population, but rather more specifically to those patients, again, who met Monarch E eligibility, but also had a high Ki-67. And so some data that we have now seen emerge comes from the sort of preliminary overall survival data that was looked at with 27 months of follow-up. Again, this is a very early time point. This was not a predefined OS analysis. This was simply an exploratory look at the time of putting data together for the FDA submission. And what you see is that, in fact, there's really no difference in survival. The hazard ratio is pretty much exactly 1. If you look numerically at the survival events, numerically it is technically slightly higher in the abemaciclib arm with 96 events compared to 90 events in the endocrine therapy alone arm. However, when you look at survival within those patients who had a high Ki-67, you can see that in fact the hazard ratio here is 0.77, favoring the patients who got abemaciclib, with fewer survival events in those patients who had high Ki-67 who had received both abemaciclib and endocrine therapy compared to endocrine therapy alone. I, however, will note that this should be looked at very cautiously. This was not a predefined time point. This was an exploratory look at data, and it's very early to be looking at survival events. So again, I think to be viewed with caution, but I think the idea here was that there was at least a trend towards survival advantage in the high Ki-67 group, whereas there was no trend in the ITT population, where again the hazard ratio, that point estimate, was 1. And so I think part of the rationale for the FDA approval, specifically in the high Ki-67 group, does stem from this trend in OS, really because they want to pick a population where they know there is benefit and definitely not harm. However, I think it's important when thinking about Ki-67 to really look at the IDFS data, because again, I think survival data is very hard to interpret with 27 months of follow-up, particularly in ER-positive disease. And so what you see here is when you look at patients who had high Ki-67 and you look at IDFS in the intent to treat population, you see about a 34% reduction in IDFS events, with an absolute difference of about 6% between the two arms. When you look specifically at cohort 1, so remember cohort 1 was the population that met those high-risk criteria, having 4 or more positive nodes or 1 to 3 nodes with tumor over 5 centimeters or high grade. Within this group, you see that the absolute difference between the arms is 7%, so even larger. Because remember cohort 2, which is small, you didn't have to have those high clinical pathologic features of tumor over 5 centimeters or high grade. Instead, you had to meet eligibility by high Ki-67. But enrollment to this cohort actually occurred much later during Monarch E, and so events in that group in cohort 2 are not mature and would be very early. And so data from cohort 2 separately has not yet been shown, again, because it is too immature for analysis. But what I think is interesting here is that if you look at benefit in both high and low Ki-67, in fact, the hazard ratios for benefit in the high and low group are actually almost the same. There are, however, fewer events in the low Ki-67 group. Again, we know Ki-67 is prognostic. As you can see here, that low Ki-67 patients will have fewer events compared to high Ki-67. Therefore, the absolute benefit in the high Ki-67 group is larger. It's 7%, whereas the absolute benefit in the low Ki-67 group is smaller at about 4.5%. But I think important to realize here, Ki-67 is not predictive of benefit to abemaciclib. Again, both low and high Ki-67 patients are benefiting with similar relative risk reductions. It's the absolute risk that is larger, the absolute benefit that is larger in the high Ki-67 patients. Again, these are higher risk patients. Ki-67 is prognostic, but not predictive of abemaciclib benefit. And I think this is important because when we look at our really high-risk patients, so those patients who have 4 or more positive nodes, in fact, what you see is the majority of patients with 4 or more positive nodes, in fact, have low Ki-67. And so this is really relevant in my mind because I know these patients have high risk of recurrence and yet technically would fall outside the FDA indication because, again, to meet FDA indication, you had to have a high Ki-67. And I think this is challenging for us in clinic because, again, you have a patient before you with multiple nodes who you know is at high risk of recurrence and yet is not eligible technically by the FDA guidelines for use of abemaciclib. So again, I think important to realize that this is not an infrequent problem given the prevalence of low Ki-67 in the multi-node positive group of patients. I think the other challenge that we have is Ki-67 is a challenging biomarker because it has low analytical validity. And I will say personally at our institution, our pathologists do not routinely run Ki-67 because of this challenge where there is difficulties with seeing inter-observer variability with reading Ki-67. And because of this, the International Ki-67 Breast Cancer Working Group, in fact, has felt that getting Ki-67 reads between 5 and 30% is really not reliable, and so has felt that there's unacceptable analytic validity within this range. And yet this is the range for which the FDA indication falls, making it challenging for us in clinic. What if you have someone who comes back with a Ki-67 of 18%? Is that really that different than 20% when it falls into this range where there isn't great validity for the assay? So I think because of all these challenges with the Ki-67 biomarker and really trying to juxtapose risk and benefit with abemaciclib, in fact, when the ASCO guideline committee met, they decided to recommend use of abemaciclib really for patients who otherwise would have met the Monarch E intent to treat eligibility. So this means patients who had 4 or more positive nodes or 1 to 3 positive nodes and a tumor over 5 centimeters or high grade. And that while, in fact, again, the FDA indication is for high Ki-67, they felt that abemaciclib could be used regardless of Ki-67 value for patients who meet Monarch E eligibility. So it is looser in the guidelines than the actual FDA indication. And so I think putting all this into perspective, I think it makes us come back to our case now, because here again, you have a woman who has a large tumor, so over 5 centimeters, and has 3 positive nodes. So this patient would have met Monarch E eligibility because again, 1 to 3 positive nodes and tumor over 5 centimeters, you meet eligibility. And this is a patient, however, who had an Oncotype score sent. And at the time Monarch E was conducted, we did not have data from our responder, so it was not common to be getting genomic assays in patients and omitting chemotherapy. In fact, 95% of patients in Monarch E had received chemotherapy. Yet, now we know that even in patients who have 1 to 3 positive nodes, if you have a low Oncotype in a postmenopausal patient, in fact, there is no benefit for chemotherapy. And so this patient would not receive chemotherapy given the responder data. So it doesn't really fit into sort of the average patient in Monarch E, since again, almost everyone in that trial had received chemo. And given that she has a low Oncotype, it is possible she also would have a low Ki-67, given that it is a proliferative marker. And we see this not uncommonly in lobular cancers. So I think when I see this patient in clinic, now I feel a little bit challenged, because if I were to use the FDA indication, I would say, well, I have to order a Ki-67, and if it comes back low, as it probably would in this patient, then she would not meet FDA indication for treatment. However, this is a patient I think that has pretty high-risk disease. She's got a large tumor, 3 positive nodes, and from clinical pathologic features does have high risk. And I am now omitting chemotherapy and really want to figure out other ways to optimize her treatment. So in fact, this is a patient that I would prescribe abemaciclib to again, and does meet ASCO guidelines for indication. I will say in truth, I am not routinely ordering Ki-67 because I don't really know how to use it, because I do agree with ASCO guidelines that I would like to use it in all patients who met eligibility based on the ITT population. So I think when thinking about utilization of abemaciclib, it's not only challenging to just make sure we figure out the right patient population, but now we're integrating a new drug into our adjuvant setting, and it does come up with a lot of practical considerations. So one question would be, which patient should really get the adjuvant abemaciclib, as we were alluding to? 2 would be, how should it be administered? And 3, how should toxicities be managed? And so one thing that I think is pretty handy is this supplemental resource, which is a practice aid, which will cover a lot of this information that we're going to review about really how to practically use abemaciclib in the adjuvant setting. And so you can download this just to have a nice reference available for you for practical standards. So first question, which patients do we use it in? So I think as we've reviewed, I think given the ASCO guidelines, I think it's very reasonable to utilize abemaciclib in patients who met Monarch E ITT population. So tumor over 4 centimeters or 1 to 3 positive nodes, and tumor over 5 centimeters or high grade. And here I've written to use it irrespective of Ki-67, again, given the challenges that we reviewed with Ki-67 testing and the fact that it in fact was not predictive of abemaciclib benefit, but rather is simply prognostic. So what about when we see patients in clinic who do not receive chemotherapy? When Monarch E was conducted, we didn't have data from our exponder, and so we were not checking genomic assays in patients who had node-positive disease, and so most patients were all getting chemotherapy. And you can see this because 95% of patients, in fact, in Monarch E had received chemotherapy. But what do we do now when we see patients who have 1 to 3 positive nodes and we get a genomic assay and it's low and we want to omit chemotherapy? Does this data really pertain to those patients who are not receiving chemotherapy? My opinion is that I think it does, because we know, in fact, that abemaciclib provided benefit in patients with 1 to 3 positive nodes. And so given this, I have felt very comfortable using abemaciclib even in patients who are not receiving adjuvant chemotherapy. So what about patients who have a germline BRCA mutation? We are very fortunate now that we have data that came from the Olympia trial that looked at a year of olaparib in patients with germline BRCA mutations and found a 40% reduction in invasive disease-free survival events. So what do you do now if you have a patient who has hormone receptor positive disease that would otherwise meet Monarch E eligibility and has a germline BRCA mutation? Do you give them a year of olaparib, or do you give them abemaciclib, or do you think about sequencing olaparib and abemaciclib? And here I think we're in a data-free zone, because in fact we do not have data from Monarch E that specifically gives us outcomes for patients with germline BRCA mutations. And I think also important to keep in mind that in Olympia, only about 20% of patients actually had hormone receptor positive disease. So it was a minority of patients in this trial where we have data. So my personal opinion is that we know that olaparib is a highly effective agent in patients with germline BRCA mutations, and biologically it makes sense to use a PARP inhibitor in this population. And so my preference, given the dramatic improvement in invasive disease-free survival seen in Olympia, is to use olaparib in someone with a germline BRCA mutation. However, if I were to see a patient with extremely high-risk disease, so maybe someone who has 20 positive lymph nodes, I might be tempted to think about sequencing olaparib followed by abemaciclib, again simply because this patient has such high risk of disease recurrence that I want to try to optimize outcomes as much as I can. That being said, I think we do have to be cautious here. Again, we do not have data for sequencing. We do not have long-term safety data for doing such a sequence. So again, only to be used with caution in someone with extraordinarily high-risk disease. So thinking about safety, also important to think about toxicities that we see with these drugs. And so one of the more common toxicities with abemaciclib is GI toxicity with diarrhea. In fact, most diarrhea is low-grade diarrhea. However, it does take good counseling with your patient for how to manage that and how to inform you if they're having challenges with diarrhea, particularly very early on, where we see rates of discontinuation from abemaciclib and Monarch E being highest, particularly within the first 3 months of exposure. Beyond 3 months, really issues with diarrhea go away almost. Most of the diarrhea outside of 3 months was about 30% of people having grade 1 diarrhea and really not seeing high-grade diarrhea out of that initial time frame. This agent can also cause neutropenia. It's not so common to have high-grade neutropenia with abemaciclib. About 20% of patients can experience grade 3-4 neutropenia, but it can require dose modification and does require monitoring. So that's important to realize. The things that I worry a little bit about are risk of VTE. So there's a 2.5% risk of blood clot in patients receiving abemaciclib compared to only 0.6% in the endocrine alone arm. So clearly abemaciclib is increasing risk of blood clot. There also was about a 3% rate of interstitial lung disease. And so I think very important to warn your patients about this potential toxicity with abemaciclib. So one interesting finding, however, was despite these toxicities that we've reviewed, When patient-reported outcomes were collected in Monarch E and patients were asked how bothered they were by their side effects, in fact, patients were no more bothered than their side effects in the abemaciclib arm compared to the endocrine therapy alone arm, which I think is quite interesting. Given the risk of blood clot with abemaciclib, if you specifically look at rates based on choice of endocrine therapy, you do see that rates of VTE are higher in the tamoxifen arm. And so it's about 4% in the tamoxifen arm, which is much higher than those patients getting aromatase inhibition where it's under 2%. And so I think because of this, I think it's really important that we are cautious about use of tamoxifen in patients who may have other predisposing factors to blood clot. Because again, that rate is on the higher side, and I think one that we do have to be cautious about. Again, the diarrhea is something you do have to talk to your patients about. Median time to onset is pretty early, 6 to 8 days. I do provide all my patients with loperamide up front, telling them how to use it at the onset of diarrhea. And that they do need to call me if they're having difficulty with diarrhea, because I do hold the abemaciclib with grade 2 diarrhea, and then depending on how quickly it resolves, we'll either restart that dose when they get better or dose reduce if it took them longer to resolve their grade 2 diarrhea. So you can go from 150 milligrams twice daily down to 100 when you dose reduce. Again, we did mention this risk of ILD, so really important to warn your patients about it so that if they do have some shortness of breath or dyspnea on exertion, they are calling you and you can work it up with a high-res CT for further evaluation, and certainly important to also rule out infection as well. The neutropenia, again, not quite as common with abemaciclib as compared to other CDK4/6 inhibitors, but you do have to check a CBC with differential as well as a comprehensive metabolic panel in patients every 2 weeks for the first 2 months to monitor. So you're checking both for neutropenia as well as making sure you're not seeing elevated transaminases. One tricky thing with abemaciclib is it does have an impairment of the creatinine transporter. So it does falsely make your creatinine look high. It can make you think someone has renal insufficiency. And so when I see that, I often check a cystatin C, which will give you the GFR, and that way you'll realize if they truly have renal insufficiency or not. So it's a good way to correct for this issue with the impact on the creatinine transporter. So I think putting this all into perspective, taking this patient now, we come back to our case with a 54-year-old postmenopausal woman who had 3 positive nodes, a tumor over 5 centimeters, and a low oncotype. This was a patient that we decided, given the low oncotype, we would omit chemotherapy from, and given that she met Monarch E eligibility, I did not send a Ki-67, but rather prescribed an aromatase inhibitor with a plan for 2 years of abemaciclib. I also gave her zoledronic acid, given the data that we have for use of bisphosphonate in terms of prevention of disease-free survival events. So I think, overall, we're really fortunate now to have a new agent in the early stage hormone receptor positive space. It's been 20 years without a new agent that's been approved here. So really, remarkable to be able to help our patients with high risk hormone receptor positive breast cancer with using abemaciclib. And so I think, again, just to remember the Monarch E eligibility, which is really helpful for when you're seeing patients in clinic. And don't forget to think about these practical guidelines when you're monitoring patients as well. Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/AGM860. This activity is supported by an educational grant from Lilly. This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.